So really understanding the mechanism and how serotonin receptors work can help rationalize the side effects better. Okay, now speaking of bleeding, thus is bleeding a thing to be concerned about? If you're not on an anticoagulant, antiplatelet, if you have not come out of surgery, and so on, it's not something to be seriously concerned about if you're not really at risk. This is generally rare because, again, for hemostasis, there are a lot more factors at play than just platelet aggregation that maintain that delicate balance between clotting and bleeding. So if you don't have risks, it's generally not a super big concern. Ganon din with hyponatremia, SIAD. So in clinical practice, we have this term called psychotropic diagnosis syndrome. That was a term from Dr. Shobanji, a mental health pharmacist from MODS the NHS, where if there's a side effect that's kind of weird, they always blame the psych med first. But again, with the rare side effects, and these can be potentially serious, yes, you have context is super important. Are they at risk? Maybe they're taking other meds. So for hyponatremia, what if they're on a concurrent thiazide diuretic? Would you blame the antidepressant? Right? So context is super important. Take note of the risk factors. And generally, you'd expect these more for the SERT blockers. Okay, because platelets, SERT, 5-HT2, and SIAD hyponatremia, something about serotonin and SIAD is kind of not clear how that works. I can't explain that. Seizures, generally not a concern. Generally, unless you have like really a lot of risk factors, but generally it's not a super big concern. Yun. Manic switch is something to really watch out for. Now, if a person develops mania, as in yung expansive, irritable mood, along with the disinhibition, loss of impulse control, the impulsivity, the grandiosity, etc., does it mean that the antidepressant caused bipolar mania? No. The key word here is induction. Induction. That means the person already had underlying bipolar and the antidepressant just unmasked it. Okay? Antidepressants do not cause bipolar. They just induce manic switch. And that's very important to take note of. Because for many people with bipolar, they can come into the clinic with a unipolar depression diagnosis. They just show up with the major depressive disorder signs and symptoms. But oftentimes, their hypomania may be subtle, or the mania comes in much later, sometimes up to 10 years of a delay in diagnosis. So one way you can monitor is the medications. If they are not responding to the medications, or they seem to be getting worse due to the medications, maybe you're not supposed to be using antidepressants, because for bipolar depression, the meds are very different. Okay, so this is just to provide context for that. Okay, again, we talked about black box warning already. Falls and fractures is a long-term concern because, surprise, surprise, serotonin plays a role in bone homeostasis. That's kind of like, what? Why is serotonin everywhere? Well, yeah, serotonin is everywhere. Get used to it. It just does so many things, actually. It's kind of surprising where serotonin is going to show up next, you know? So this is long-term things. If you're thinking about long-term treatment, then you start considering that. Okay, short-term, not really a big issue. And there are some emerging stuff. You might not see this immediately in literature. Again, we go back to this sexual function stuff. Some people who stop their SSRI, SNRI, they may still experience persistent sexual dysfunction. When I say some, this is generally a rare thing because this has been documented, generally case reports, case theories, ganyan. But still something to be cognizant about, and not something you want to lie to people about because then they will stop trusting you. Generally, for some people, the sexual dysfunction could be due to the depression, so you treat the depression, the sexual dysfunction might actually go away, or there might be tolerance. But for a small amount of people, you know, we have seen PSSD, so just be wary of that then. Weight gain, although this is a bigger concern with the non-SERT blocker we have than the SERT blocker due to a mechanism I'll talk about in a bit. Tardive dysphoria, that's kind of, we're not really sure how that is. So you might have seen reports in forums about people who take antidepressants and then they feel emotionally blunted, like they feel like zombies. This is not to deny that it exists, but this is more of, we're not really sure what's going on there and how rare exactly it is. Because in practice, I personally haven't seen this. We're really seeing this more in case reports. But again, if they don't learn it from you, and they learn it from somewhere else, they're not gonna trust you anymore. So personally, my take is to be honest, but not to the point that you scare the person. So consider their context, their risk factors. So if a person is kind of young, they're not on any meds, I'm not going to tell them about the bleeding stuff because it's not a concern to them at all. If it does become a concern, that likely means they had an underlying bleeding disorder that we just didn't know about. Ganon yun. Okay? So context is super important for these things. So when you look at the side effect profile, you see the differences. Again, you will go back to the pharmacology if you want to rationalize it. For example, why does paroxetine have anticholinergic side effects? Because it blocks the M1 receptor. Why is mirtazapine generally sedating? Because it is an H1 antagonist. But conversely, why does mirtazapine have less nausea, vomiting? Because it does not block SERT. Therefore, its increase of serotonin in the synaptic cleft is not as potent, perhaps. So less, issues with the postsynaptic serotonin receptor effects, maybe. Right? So again, you go back to the pharmacology. That's why I dichotomize it between SERT blockers and non-SERT blockers, right? Because then it becomes very easy. Because generally, so everything here except mirtazapine is a SERT blocker. So these are all the drugs we have in the Philippines. Everything besides mirtazapine will block SERT to a degree. So you'll notice the stark differences. Dito pa lang sa nausea and vomiting. So maybe, trimipramine, amitriptyline may block SERT to a lesser extent. So less nausea, vomiting. But then notice sexual dysfunction is kind of still off the charts. But then with mirtazapine, consistently like halos wala, ganyan. Diba? So you really go back to the pharmacology. And then I added this other column here. Please mind this column here at the rightmost. The financial toxicity, very important in clinical practice. Please steer clear of financially toxic drugs. Given that we have drugs that are just kind of in between like 20 to 35 pesos a day in terms of cost, and then you have those that are like 90, 120. Just don't go for those anymore. Because generally, when you look at efficacy, all of these work. All of these are better than the placebo. So when you look at the side effect profile as a difference, yan lang. The side effect profile, cost, interactions. Yan yung mga factors to consider natin. So why go for something like desvenlafaxine, vortioxetine when you have the relatively less costly? Given that in the Philippines, cost is a very significant factor for adherence. I've seen so many people stop antidepressants because they can't afford, or they have two meds and then they stop the more essential med because they can't afford both, so they drop the more essential one in favor of the less essential one. So it's like, so again, pay attention to the financial toxicity. That's why our focus is on those three lang na naka-highlight in yellow. And yung pinaka-ano. Of course, there are scenarios where you would go for the other meds if, again, nausea, vomiting, sexual dysfunction is a big concern. Yan. Or if you want something more sedating, you go for the others. Okay? Side effect management, this is generally common sense. So for instance, for dizziness, nausea, when would you less likely experience these? Well, when you're asleep. You will less likely feel it. I'm not saying you won't, because I have met people who I advise them, okay, you're getting a headache, take this in at night. But there are people whose headaches are still strong enough that they feel it while they're asleep. So it depends. But there is a lower chance you will feel some side effects when you're asleep, so you can move that to night. Or again, insomnia sedation, it depends. You have to adjust accordingly, okay? Plus, mind the sleep hygiene. Sleep hygiene, stimulus control, you can look those up. Very important non-pharmacologic advice. Very essential, okay? Very essential. No time to cover it here. We'll cover it in the other module on sedative hypnotics na lang, okay? And then, the commonsensical stuff for GI side effects.